Hi everyone, my name is Anita Arsovska and I'm the Associate Commissioning Editor of the World Stroke Academy, the educational platform of the World Stroke Organization. Today, I have the privilege to interview Patrik Michel, head of the Stroke Center in the Neurosciences Department of the Lausanne University Hospital and Professor of Neurology at the University of Lausanne, Switzerland. Professor Patrik Michel is actively involved in the Swiss Stroke Society, the European Stroke Organization, and the World Stroke Organization as a board member. He lectures at national and international conferences and at the European Master's Program for Stroke Medicine. Professor Patrik Michel has founded and directs the Acute Stroke Registry and Analysis of Lausanne, the Astral Stroke Registry, which serves as a basis of multiple research projects and international collaborations. He is on the editorial board of the European Stroke Journal and the International Journal of Stroke. Professor Michel has published multiple articles and book chapters on stroke syndromes, neuroradiological topics, and stroke management. So the occasion for today's interview is the paper that Professor Patrik Michel co-authored together with Professor Hugh Marcus, and this paper was recently published in the International Journal of Stroke. This paper is an excellent review of the latest options for treatment of posterior circulation stroke and was chosen by the World Stroke Academy as the paper of the month. So Patrik, welcome and congratulations on your publication.
Hello Anita, many thanks for bringing me to this podium and to be able to discuss these findings, this kind of review of treatment and prevention for posterior circulation stroke.
So diagnosis and treatment of posterior circulation strokes can sometimes be very challenging for the neurologist. In your paper, you have covered interventions in the acute setting and also secondary prevention strategies, with a special focus on areas where management of posterior circulation strokes differs from that of stroke in general, and you have highlighted recent advances. So my first question to you would be, can you summarize the main findings regarding IVT use in posterior circulation strokes?
Thank you. So it looks like intravenous thrombolysis does work for posterior circulation stroke for about any situation, minor strokes, major strokes, with occlusions, without occlusions, and even for basilar artery occlusions. Now, the main problem is, of course, that we don't have any randomized trials specifically for the posterior circulation. But like in the overall findings where IV thrombolysis in general for stroke seems to be efficacious both for minor, moderate and severe stroke, this seems to be the case also in posterior circulation strokes. There are a couple of comparisons between thrombolyzed patients with the posterior circulation as opposed to thrombolyzed patients of the anterior circulation. The most important one is the one from the VISTA registry. And these analyses have shown, number one, that it is at least as effective to thrombolyze the posterior circulation as the anterior circulation. And number two, that the hemorrhage rate seems to be about 50% lower in the posterior circulation. And this is presumably due to the fact that there is less volume of tissue which is infarcted, so there is less risk of bleed. Finally, an interesting finding is in basilar artery occlusions. Again, only retrospective analysis, but there in the BASICS registry at the time, about more than 10 years ago, we were able to show that thrombolysis seems to work as well in basilar artery occlusion, but number one, it works mainly in severe basilar artery occlusions, and B, it does not work enough, of course. It does improve patients, but not as much as, of course, as it should improve patients.
Thank you. So what about endovascular treatment of basilar occlusion?
So as you know, there are essentially 4 major trials now that are known. And the initial 2 trials, the Chinese BEST trial and the Western BASICS trial, they did not show significant improvements despite some trends. The BEST trials had to be stopped prematurely because of a high crossover rate. And the BASICS trial was carried on to the end point as planned. In the BASICS trial, the interesting 2 findings were, number 1, about more than 70% of the BASICS patients have received thrombolysis before endovascular treatment, which may decrease the effect of endovascular treatment. The difference is less important. And number 2, that it seems that the minor strokes in BASICS, the ones with NHSS below 10, they particularly did not have a benefit, but the major ones probably did. So these were some subgroup findings which are interesting. Now in the 2 Chinese trials, attention 0 to 6 hours and Peyoche 6 to 24 hours in basilar occlusion that were presented at the European Stroke Organization conference this spring in Lyon. These trials, as you remember, were positive, clearly positive, which is a good news. They were not very strict selection criteria. I mean, they were basically, they didn't have to have signs of major posterior circulation damage on radiology. They were positive. Now, the interesting thing is that the 2 recent Chinese trials, they had relatively low thrombolysis rates. The attention trial had about 30% thrombolysis rate, and the Peyoche about 17, also because these were late patients. And of course, if you have lower thrombolysis rates, the likelihood to be able to show an effect of endovascular treatment is higher. So this may explain in part why these trials were very positive, whereas BASICS was not as positive. And fortunately, in those trials, we do not yet have very detailed results on subgroups. We have some basic results, but for example, we do not have results on patients with an NHSS below 10 to see whether the same is true as for BASICS, whether these patients with relatively minor strokes do not have a benefit from endovascular treatment. So overall, endovascular treatment for basilar artery occlusion does seem to work. It seems to work especially well in Asian patients. It seems to work especially well if the patient does not get IV thrombolysis before endovascular treatment, and it does seem to work especially well in more severe strokes.
And what about occlusion of the vertebral artery or isolated posterior cerebral artery occlusion?
These are good questions. So there are a few publications either published already or in publication in press very soon on that issue, but the results on the posterior cerebral artery revascularization, both endovascular and intravenous, are very heterogeneous. So some of these studies that are being published now and meta-analysis show that there may be harm even to do endovascular treatment in these patients. Other meta-analysis show neutral results, and one that we have published last year showed a potential benefit. So it is really not quite clear whether these medium and smaller vessel occlusions do benefit from endovascular treatment. So hopefully we will get some randomized data in the future, but I'm not aware of any trial. For the vertebral artery occlusions, it's even worse. We have virtually no data. Within the BEST trial, there were 12 patients randomized with isolated intracranial vertebral artery occlusions. And these patients had a very poor outcome if treated with endovascular therapy. But of course, we cannot conclude on very small numbers of patients, but we definitely need a lot more data before we conclude that an isolated vertebral artery occlusion should receive endovascular treatment or not.
Thank you. So I'm interested in what is the best option for secondary prevention of posterior circulation strokes.
Well, if we start with medical treatment, it is very similar to what we know from the anterior circulation. Again, in the absence of posterior circulation, randomized studies, but many of the posterior circulation patients were included in the overall prevention trials. So aggressive management of blood pressure, cholesterol, good control of diabetes, antiplatelets, basically the ones that have been shown to work either in the chance of point trials or in the Thales trials, that is combination of aspirin Plavix or aspirin and ticagrelor in the early phase in patients with mild to moderate volume or severity strokes should be performed, especially if the patients seem to have a high risk of early recurrence. But in the long term, it's again monoplatelet antiplatelet therapy, either with clopidogrel or with aspirin or similar antiplatelets. So these are very similar or identical, I guess, to anterior circulation strokes in terms of medical treatment, but also in terms of lifestyle treatment. And again, for lifestyle treatment, we have now more and more evidence with trials like Stroke Card that these patients do benefit from lifestyle interventions, regular doctor visits, instructions to the patients and the families, and physical activity. This has also been shown in trials like the Sampris trial, even for intracranial disease, that these patients have benefit if we do aggressive medical and lifestyle management.
Thank you. We know that widely used screening protocols such as the FAST test or the NHS score are less sensitive for posterior circulation strokes. So what is your opinion? Do we need more specific stroke scales to better evaluate posterior circulation strokes?
I think it is both. I think stroke physicians have to be aware of what you just said correctly, that these regular NHS scales, they are less good for assessing posterior circulation strokes. Again and again, it has been shown that the NHS underestimates the deficits and the long-term handicap that will ensue in posterior circulation stroke. As an example, in certain cerebellar strokes, you may have a patient who cannot walk, who has to crawl on all four extremities, but he may have an NHSS of 0, 1, or 2 because of a bit of hemiataxia. So this is, of course, a clear underestimation of the deficit, or isolated hemianopia from occipital stroke will prevent somebody from driving a car or reading a book, and this only gives you 2 points. And the good news is that there has now been a nice work in publication of a posterior circulation NHSS. This was by Fana Alemseged and Bruce Campbell, published a few months ago. And the main difference there is that they do assess also swallowing and whether people can cough. So dysphagia issues, which is a major element for posterior strokes, also for prognosis. And then adding these points, also ataxia on both sides, hemiataxia right and left. This will improve clearly the assessment of these patients. So each stroke center has to experiment with this new scale, whether it wants to implement it, but I would suggest to try it.
Thank you. And at the end of this interview, would you like to add anything else to share with our audience?
Well, maybe two other points regarding secondary prevention. We have not mentioned yet the possibilities of stenting of extracranial and intracranial symptomatic stenosis of the posterior circulation. So intracranial stenosis, both of the vertebral and the basilar artery and the PCA, probably at the current time is not recommended. The meta-analysis in this regard are rather negative. That is, we do more harm than benefit in such patients. However, in extracranial vertebral artery stenosis, typically this is at the origin of the vertebral arteries. If you perform stenting in a patient who had recently symptomatic vertebral artery disease going into the basilar artery, they seem probably to have a benefit, not a major benefit, but some benefit in the meta-analysis. That is a combination, the meta-analysis was a combination of smaller randomized trials like the VIPA trial and part of the Sampris trial. So it should be considered in some patients to perform stenting of the extracranial arteries, maybe particularly if they have recurrent events under optimal treatment. And in our article, we actually have drawn a little diagram that can help you decide which patient at what time point could possibly benefit from this treatment. Now, the other point, just to come back to the symptoms of posterior circulation stroke, it is, I think, important to try to differentiate, symptoms from posterior versus anterior circulation stroke for many reasons that you know. Now, one important thing is that posterior circulation strokes have a tendency to be misdiagnosed or not recognized. Two classical examples that you all are aware of are isolated vertigo, acute onset or night onset while people are asleep and are wrongly diagnosed as peripheral vertigo. Of course, you have to look out for some red flags, like the patient who cannot walk anymore, the patient with a lot of risk factors, or of course, different type of nystagmus on eye exam, or also absence of peripheral otoneurological signs on exam. The other typical example is, well, the basilar artery occlusion. If people do not wake up from sleep or go into acute coma from basilar artery occlusion or an acute locked-in, again, these patients are unfortunately sometimes missed in the pre-hospital or emergency room phase, which is, of course, a catastrophe. So again, I want everybody to try to repeat again and again the symptoms, signs, classical and less classical presentations of posterior circulation disease. And we have also written another paper, actually, which is published now at the same time in the international stroke journals on the different syndromes of the posterior circulation with Dr. Salerno. So I invite you to also consult that other paper.
And there is also an excellent webinar that you actually have on the website of the World Stroke Organization regarding posterior stroke. There is everything there, starting from the clinical symptoms, the clinical picture, diagnosis and treatment. So I also invite the audience to look at this excellent webinar that was done by you. So that was excellent. Thank you very much, Patrik, for your time, for sharing your expertise with us. Your scientific contribution to the World Stroke Academy and the World Stroke Organization is highly appreciated. Thank you very much.
Thank you, Anita, for all the good work of the World Stroke Academy. It's wonderful to see how the quality and also the quantity is improving constantly, and many warm greetings to you in Skopje.
Thank you very much. Looking forward to seeing you in person in the next congresses.
Thank you.